So, what I'm going to talk about today are lung infections, and we're going to do it looking at basically two different things or three different things. We're going to start with how to scan. So, there is actually a way that I think is the best way to scan things personally. We're going to talk about what to look for. And then finally, we're going to spend a little bit of extra time talking about the big thing right now, which is COVID-19. And also, I don't have the chat box up. So if anybody has any questions, if there could be like one person who's like the moderator that can please interrupt me if you have any questions while I'm talking. All right, let's start with this, how to scan. Now, with most of our basic lung pathology, we have pleural effusions, we have B-lines, and we have pneumothoraces, which are kind of like basics of lung ultrasound. Now, for all of these three things, we can look at our patient supine. We don't have to manipulate them. We don't have to move them at all. We can just look anterior. We can look lateral. Now, the problem with this in lung infections is that the lobes of the lung, you have to look at the lower lobes. And it's not that this down here at the base is like the lower lobe. That's actually not how it works. Now, I apologize for putting x-ray on here. I'm not like a huge fan of x-rays for lung pathology, but this is the best thing I could find that kind of talks about where the lobes are. Now, if you look over here on the right side, right bottom here, you see that the lower lobe is basically like the back part of the thorax. So you really can't look at the lower lobe adequately unless you've looked at the posterior aspect of the thorax. So don't think about the lobes as like from top to bottom. Think about them as almost staggered in a diagonal orientation. So to look at the lower lobes, you have to look at the back of the chest. And that's kind of the extra thing with lung infections that you need to look for. So you definitely can start the examination like this, especially if your patient's intubated, but you have to look at the back part of the lung. Super important with these potential lung infection patients. Now, as far as protocols, exactly how you scan these patients, there are a lot of different ways. There's like super complicated, like 28 zone protocols that I think might work in some situations. But for me, I hesitate to say that I'm lazy because I feel like that's kind of like self-sabotaging. What I like to say instead is that I like to work efficiently. And instead of focusing on, 28 lung zones, what I do is basically 3 per side. So I do an anterior region, a lateral region, and then a posterior region. Now remember, this isn't like corresponding to any specific lobe of the lung necessarily. And I think that that's okay because when you're trying to identify a pneumonia or an absence of a pneumonia, you don't really need to, like, let's say you find a pneumonia. I don't think it's that like clinically relevant for us in the emergency department to say, well, this is definitely in the middle lobe or this is definitely in the anterior, in the upper lobe. That's not important for us. We just need to say yes or no. Is it bad or is it not bad? That's really what's important to us. Now, what is important is to make sure that you evaluate the whole lung. That's why I divide it into like 3 regions to make sure that I remember to do the whole thing. Now, there is a spot right up here on the left side of the image where it's kind of like missing. This is the scapula, and you can image through bone. It's kind of a known issue, but you're still getting a fair bit of the lungs, and most of pneumonias are going to be in areas that you can see. But know that there's limitations to ultrasound, just like with everything else. Now, if you have an awake patient, somebody that can cooperate with you, what I often do is I have them kind of, if they're sitting upright, I have them kind of give themselves a hug, or imagine, how you guys might orient your patient or have them sit when you're doing an LP, when they're sitting up. You have them kind of like lean over with their arms kind of on a procedure tray. So you want to have them in that kind of an orientation. And what that does is it actually helps spread the scapula a little more laterally. It might give you a centimeter or two more of the lung to actually look at. So that's something that you can do extra. Now, if you have an intubated patient, what I usually do is I do this with help. So I have another person in the room. I'll move them over to their side, making sure that somebody is paying attention to the ET tube. Put the bed rail up on the side that you're going to be moving them to. That's obviously going to be the side towards the ventilator. And then I look at them basically on their side. Now, if you're looking up here on this side, it'd be a lot easier to look for that, the whole lower lobe. You're going to have to be a little bit creative with the more dependent side, whichever side that might be. Usually what I do is I have one hand on the shoulder, kind of rock them forward more towards the ventilator, just tilt them down so I can see down here a little bit easier. Now, as far as the probe to use, the curvilinear transducer is a probe I would suggest for the vast majority of lung pathology. It's got the best combination of resolution, depth, frequency. The phased array has an advantage in which, like, the window or the window that I can look for, it can look in between the ribs. But I'll show you in a bit why that doesn't really matter with the curvilinear transducer, because there's a way you can get around that. And then with using the linear transducer for lung pathology, it's too focused. Usually when I'm looking for lung pathology, especially infections, I want to have a much broader window to look through, kind of like a more eagle eye view. And so that's why I like using that curvilinear transducer for anything in the lungs. Now, as far as what I'm actually looking for, this is my super high-tech representation that I made on Keynote of the pleural line. So we got a rib over here, and we have the pleural line right here. And what I'm doing is just straight up pattern recognition. Do I see this image that I'm showing you right now, or do I see not this image? It's just the easiest way for me to think about it. Yes or no. So is this pleural line, is it just like a white, nice line with nothing coming off of it, no B lines, no subpleural consolidations, or not? That's really what I'm looking for, is pattern recognition. Now, as far as scanning, I use, like I said, the curvilinear transducer, and I place the transducer with the probe marker facing up so that I can look at multiple rib spaces in a row. It's just more efficient, and I'll lawnmower back and forth. Now, in this example, I'm starting off anterior, and you definitely can, but for me, I'm honestly, if I can help it, I'm going to start by looking in the posterior aspect of the thorax, which is the lower lobe. Let's start there first, because that's, statistically speaking, the most likely place for infections to be located. Now, let's talk about how I look at the back. So what I do first is I identify where the abdomen is. So if you look here, this over here is the spleen. There's a little bit of the kidney right there. So when I see abdominal organs, I know that that is basically the limit of the thorax. I'm right underneath the thorax, right? So what I do is I find that first, and then I go up a rib space or two above that, and that's where I start my examination. The pleural line itself is, going to be, the end of the lungs or the thorax is going to be different in everybody. So that's why I don't think about it as like a specific rib space. And then don't forget, there is lung all the way up here. So I scan in between the scapula and the spine, going all the way up until I get to basically the apex of the lung, which is all the way up here. Now, I'll do the same thing on the side. And remember, this is all pattern recognition. It's, do I see a pleural line with a bunch of A lines or not? So I do it in the lateral areas as well. Now, let's say right here at this spot, I find a couple of focal B lines. I find an irregular pleural line. Something looks different than what I am used to seeing or what I want to see, right? So what I do there, so I identified this one spot. It's kind of like I've been using a broad, maybe the coarse tuner on a microscope. And then when I get to a section where I find an abnormality, then I will actually turn the transducer to be parallel with the intercostal space. And so now I'm getting the whole area in that section, or that whole intercostal space, and I'll fan back and forth within that intercostal space and really look very more diligently in that area. And this is kind of how I get around the whole advantage of the phased array, which is you don't get ribs in the way. You can do the same thing with the curvilinear, and I'd argue to even get a much bigger field of view by doing it this way. All right, so let's talk about the sonographic findings of pneumonia. Now, there are a bunch. There's like multiple different ones, and we're going to talk about what each of these look like in turn. Now, I realize that probably these are going to be a little bit of a review for the vast majority of you, but we're just going to go through them anyways to make sure that we're all kind of in the same spot when we talk about this. So let's talk about B lines first. B lines are things that are present in many different lung pathology, but they are definitely present in pneumonias. So let's talk about B lines first by going back and talking about what A lines are. Now, what A lines are is they represent an area of the lung that is predominantly air-filled. And it looks like this. Again, high-tech representation. Here's that pleural line, here's a rib, and these repetitive horizontal artifacts are called A lines. And here's what they look like on your ultrasound. Now, One thing that I myself would say initially when I started doing lectures is they meant that the lung was normal. That is not the case. It does not mean that this is a normal lung. It just means it's a predominantly air-filled lung. So you can see A-lines in COPD, asthma. You can see it in regions of the lung in a PE where you don't have any atelectasis or necrosis or anything like that. You can see it in a pneumothorax even. So A-lines do not mean normal. They mean air-filled lung. Now, the way that they are formed, you have these ultrasound machines, and the way they work is just sonar. So they send out a sound wave. When it bounces off, it bounces back to the transducer. And the amount of time it takes for that sound signal to come back is how the ultrasound machine determines how far it is from the transducer, right? Air is a reflector of sound. So what happens is you have a sound beam from the ultrasound transducer. It's going to come down, hit that reflector, which is the pleural line, which is air, and bounce back. All right. So that's kind of like the basic thing about how ultrasound works in general. So let's talk about A-line. So we have that same pleural line, and we have a transducer, and it'll sound out a sound wave, bounce off that pleural line. We'll say it took, I don't know, T amount of time for that to make it back to the transducer. The ultrasound machine thinks that all sound moves at the same speed in the body, so it generates an image of that pleural line at T distance away from the transducer. But what will happen, the sound wave is, the ultrasound machine is continually sending out sound waves, listening. The next one will come back, hit the pleural line, hit the skin, hit the pleural line, and then go back to the transducer. And so instead of taking T amount of time, it might take 2T amount of time, and so on and so forth. So this is how A-lines are generated. And they look like this. Now, one quick thing to remember is that everything underneath this pleural line in an air-filled lung is all artifact. This is not lung tissue. This is artifacts in an air-filled region. And you can actually see A-lines apart from the lung. You can see it in intestines. You can see it sometimes when you have subcutaneous air. Sometimes basically anything that's air can create these A-lines. We just see them most commonly in the lung. Now, as far as how B-lines are generated, there's basically two main theories. Now, this theory on the left here, this is the thickened interlobular septa theory. It's one kind of theory. I don't really agree with it necessarily, just because there's not been any experimental evidence to prove it. There's just kind of CT correlations that was done basically by one guy in France. Utmost respect for the guy, but experimentally, there's been another model that has actually been shown to generate B-lines, and it looks a lot more like what I think would happen. Now, remember, I said when you have air, it actually reflects sound, right? So imagine that you have this blue circle in the center is like a fluid-filled or debris-filled alveoli or alveolus, surrounded by a bunch of air-filled alveoli. So you have a sound beam that's represented by this dotted line right here. This sound beam is going to come down, and sound is able to go through water or tissue pretty easily, right? It doesn't bounce off of it. It goes through it to varying degrees. But what will happen is once that sound beam hits the border of a fluid-filled or debris-filled alveolus and hits the border between that and an air-filled alveolus, it'll bounce. And if this alveolus is surrounded by a bunch of air-filled stuff, it's just going to create this different type of reverberation artifact called a B-line. So that's how these things are generated. So here's a kind of cartoon of what we're looking at, and then over here on the right side of the screen is what actual B-lines look like. So really, that's just, theories as to how they're generated. The main thing you have to know is that B-lines mean increase in density, and A-lines mean predominantly air. And the curly B-lines, of course, of the X-ray are the same thing as the sonographic B-lines. Now, as far as criteria for B-lines, they have to be vertical artifacts. They move with respiration, and they extend down to the bottom of the screen. Now, as far as an actual number that you have to have the depth as, there are some of the older studies that say they need to be 21 centimeters, but I think that's way too deep. I usually have it if I'm looking for B-lines. I usually try to have my depth at around 10 centimeters or so. Now, I will say that that's not really based off of any objective multi-centered data. That's just what I do, is I have my depth usually about 10 centimeters or so, and I'm able to see B-lines. Now that's important because sometimes you might have really small comet tail artifacts, which are just tiny B-lines that just extend like a half a centimeter or so from the pleural line. Those are not true B-lines. They have to actually extend down to the bottom of whatever visible screen you have, and 10 centimeters seems to be the amount that I pick up most of the B-lines at. Now, what's important about B-lines is that they mean an increase in density. So we think about this probably most commonly with this, right? With cardiogenic pulmonary edema, you have a patient with a super low ejection fraction, all the fluids can get backed up to the lungs and create these B-lines. That is definitely probably the most common pathologic state that I'll find B-lines in. However, realize that you can see B-lines in a bunch of different pathologies. It's definitely not present only in cardiogenic pulmonary edema. And for this lecture, for us, know that it is definitely present in pneumonia. Now, as far as pneumonia and B-lines, usually we're going to find the B-lines focally, just kind of in one area, or what we call multifocal. So multifocal meaning you see a bunch of B-lines in like one area and then like completely clear lung, and then you might see B-lines in another region of the lungs just focally in that area. That's what multifocal means. And then diffuse would be just B-lines in all lung fields. Diffuse is more likely to be something like acute chest syndrome, or sorry, HAPE, high altitude pulmonary edema. You'll see it in cardiogenic pulmonary edema as well. So for pneumonia and B-lines, that's more focal, so just in one area of the lung, or multifocal, a bunch of different areas of the lung. All right, so that was B-lines. Let's move on to pleural line abnormalities. That's basically, instead of seeing a nice crisp white line, you're going to see this, a really lumpy, bumpy white line of that pleur. So we got ribs with rib shadows kind of in between here. I have my probe marker in a sagittal orientation in this picture. I've not yet seen a situation where I have an irregular pleural line and no B-lines. So they usually see those two things together, but in the literature, sometimes they're talked about separately. So that's why I'm kind of mentioning it as a kind of separate thing here. You can look at this with the linear probe if you want. Just an example, this is a more normal pleural line. So it's pretty thin, it's well-defined. And then you look at this one over here, a very irregular pleural line. Another thing that has been shown to be present in patients with a lung infection. All right, let's talk about subpleural consolidations next. Now, subpleural consolidations is something that, to be honest, it's kind of like a misnomer. Like, it's not like a great way to describe it, but it's just the way they have been described, and that's how we do it. The reason why this is maybe not like the best way to describe what this is because technically anything that you can see with lung ultrasound as far as pathology is subpleural. Like, B-lines are subpleural. A big lobar consolidation is subpleural. Like, everything that you can see is subpleural. So it's kind of strange. I sometimes mention this as a small pleural consolidation because in the literature, most of the time when we're talking about subpleural consolidations, we're talking about a little area of consolidation that is less than 3 centimeters in diameter at its widest diameter. That's usually what we're talking about when we mention subpleural consolidations. And this is what they look like. So this is a patient that I saw that I had a pretty high suspicion of septic emboli. And you can see right here we have a nice rounded little consolidation and an eruption in that pleural line with a bunch of surrounding B-lines. This is more likely to be present in an inflammatory process like a pneumonia when you see, or a septic emboli. When you see B-lines, irregular pleural line surrounding B-lines around it, irregular pleural line as well. When you see all these things together, it's more likely to be just inflammation in that region. Here's another one. So right here, and I'm trying to get parallel to the ribs here. So that's why you can see like a nice pleural line and it kind of goes away for a second because I'm actually getting onto a rib. But actually, let me pause it right there. So this right here is the pleural line. This is a normal pleural line. And you see that dip right there? That is a subpleural consolidation. And this is the patient's echo. Now, what do you guys think is going on there? So I have a, I'm assuming that all of you mentally are like saying a bunch of things on differential diagnosis. So I'm assuming that one of you said there's a booger on this valve. There is, in fact, a booger on this valve. Good job, person who said that. This is a subxiphoid view. This is the liver. This is the right side of the heart, left side of the heart. And right there, we have a big flappy thingy on the tricuspid valve. That is a endocarditis. And the previous picture, this one over here, is the septic emboli from that tricuspid vegetation. This is another thing that can cause a subpleural consolidation. It is lung cancer. So usually when I see something nice and round in a patient that is not super sick but has had some B-type symptoms, I'm much more likely to think something like this is actually a cancer. It's just another thing that can cause it. This one right here is another one that in the probably 5-ish to 10-ish years ago, this was pretty popular in the ultrasound literature. So see it right here. I know that I mentioned, use the curvilinear transducer, and in this one I'm using the phased array transducer, but forgive me. This one right here, that is a subpleural consolidation right there in the presence of a pulmonary embolus. So pulmonary emboli can actually cause these subpleural consolidations as well. All right, so that was subpleural consolidations. Let's talk about pleural effusions, which probably has the broadest differential out of all of them. I know this is probably going to be a review for a lot of you, but as far as where to place a transducer, this is the one where we basically place it in one spot in everybody. What we want to do is we want to angle that transducer. We put it in a very similar place that we look for the traditional FAST examination, but we're going to move the transducer up a little bit towards the patient's head, trying to get an image that looks just like this. So we have the liver over here, we have the kidney over here, and looking at that image, I want to talk about two signs. We have something called the mirror sign and something called the spine sign. Let's talk about my less favorite one, which is the mirror sign. Now, remember I mentioned that when you have air, it makes sound bounce off of it, right? And remember I also mentioned that the way that the ultrasound machine kind of finds things is it sends out that sound waves and it waits for reflections to come back, right? So anything that reflects sound is going to be white on ultrasound. So let's take this right here. Let's take this little guy right there. That's a little kind of divot right there in the liver. Now, one sound beam will come down and it'll hit that thing, and some of that will reflect back. It takes, we say like X, I don't know, a random number, X amount of time for that sound signal to make it back to the transducer, so the ultrasound machine thinks there's something at this distance from the transducer, which is right up here, right? Okay, so we have that. Now, another sound beam will come down and hit this reflective surface. This right here is an air-filled lung. So the ultrasound machine, the sound signal will come down, hit that reflective surface, hit that little echogenic particle, come back to the diaphragm, and then make it all the way back up to the transducer. So instead of taking like X amount of time, it took X plus 2 amount of time. Now, the ultrasound machine assumes that everything moves in a straight line in the human body, which is not true because of all this, this air. And so because it took X plus 2, it thinks there's another one of these on the other side of the diaphragm, when in fact, this is a mirror image of this. All that to say that if you see identical or very similar echo texture above the diaphragm as you see below the diaphragm, that means that the thorax is air-filled, not fluid-filled. Now, my favorite one is something called the spine sign. It's the one that, to me, is the most useful. You see those little arches right there, kind of deep to the liver and the kidney? This is the lumbar and low thoracic vertebral bodies. Now look at what happens to the spine as the diaphragm starts. It just kind of like disappears, right? Here's what happens. I mean, obviously the patient still has a spine in their thorax, right? But because of all this air in an air-filled thorax is actually preventing the sound beams from the ultrasound transducer. It's preventing the ultrasound beams from actually getting to it because air reflects sound. The sound from the ultrasound machine can't go through air, right? So if the ultrasound machine can't see it, the ultrasound machine does not know it exists. So if you see a negative spine sign, the patient has air in their thorax, so not a pleural effusion. This is the opposite of both of those things. So we have a negative mirror sign. What's above the diaphragm is a different echo texture than what's below the diaphragm, right? We have this hypoechoic fluid collection. Additionally, we have the spine extending all the way up past the diaphragm right there. The reason that the ultrasound beam can now see this up here is because this fluid in that pleural effusion is transmitting sound to those thoracic vertebral bodies. So we have a positive spine sign, a negative mirror sign. Those are things that rule in a pleural effusion. So just for reference, we have abnormal on the right, pleural effusion, and normal on the left, no pleural effusion. Now, sometimes you're going to see little wispy thingies, especially in infections in the pleural effusion. When I see this, I'm much more likely to think that the patient has a complex pleural effusion, or they might actually have an empyema. Now, let's talk about the more important parts of diagnosing pneumonias or lung infections, and those are bronchograms. We basically have two broad types. We have air bronchograms and we have fluid bronchograms. Let's talk about what I think is the most important one first, and that is air bronchograms. Now, these air bronchograms are basically the same type of air bronchograms that you see on a CT scan or on an X-ray. They're just sonographic air bronchograms, and we have two different types. We have static air bronchograms and we have dynamic air bronchograms. Let's talk about static air bronchograms first. So this right here, this is a normal lung. I won't say normal, it's a lung without sonographic pathology. We have the pleural line right here. We have maybe an A line down here. We have the rib with the rib shadow, kind of a shadow of a rib that's off the picture right here. This is not pneumonia or not consolidations. Oh, another thing that I have to mention is that when I mention bronchograms, when I mention bronchograms, what I'm talking about is I'm talking about bronchograms that are within a consolidation. So this right here is not that. So this is normal and this is abnormal. We're actually able to see lung tissue. If you can see lung tissue, that's always pathologic. You should never be able to see lung tissue because lung tissue should be air-filled and the ultrasound machine can't see through air, right? This is a left retrocardiac pneumonia that I saw that was initially missed by the X-ray. I know that it's left even if I wasn't there, even if I wasn't the guy that did this, because I see the heart and I see this is right behind the heart. So all of this white stuff here, these are air bronchograms. So you see this in a patient in whom you have a pretest suspicion of a pneumonia, this essentially diagnoses your pneumonia. And these are called static air bronchograms. Now, when I say static, what I mean to say is that they're not really moving independently of the lung. So if the whole lung moves, the little white little dots and lines that you see in here, which are the bronchograms, they'll move the same distance as the lung. That's what a static air bronchogram means. So this was a patient that I saw that had COPD. And had some wheezing on his examination, but had a little bit of more of a cough than normal, a little more productive, and had a low-grade fever. So we're talking like 100.9-ish. This was what I saw in most of this patient's lung. So you guys just mentally just think about what this looks like. If you just saw this everywhere, what would you guys think? I mean, this is a pleural line. Maybe some A lines down here. I don't see any B lines. I don't see any subpleural consolidations. I don't really see anything. This looks fine to me. And I even see lung sliding. So I'm like ruling out a pneumothorax because, you know, they can have pneumothoraces sometimes. But remember, when you're looking for pneumonia, you have to look in all regions of the lung. So I went digging. I went exploring. Kind of wandered around the guy's chest with my ultrasound transducer. And I found a section that had a bunch of B lines. So you see like one area at the very beginning of the clip, just a bunch of, no B lines whatsoever. And then I go down to another area and a bunch of B lines. So that made me think, man, there's one region that has a bunch of B lines. I better look even deeper, even more in depth. So what I did was I went down a little bit further and I found this, a huge consolidation right here. This is all lung tissue that we're seeing. A pleural effusion, right there, that little sliver of black is a pleural effusion. And then this is the diaphragm, and then over here is the liver. So this is a huge lobar consolidation that I was able to find because I did a scan throughout the entire lung. I didn't just look in the anterior and lateral, I looked in the posterior aspect, and that's where this pneumonia was. It was purely a lower lobe pneumonia. So here's the whole thing. A lines, moved down a little bit. B lines, focal B lines. Was curious, went down a little bit further, and found this big lobar consolidation, an abnormal finding. And this guy ended up getting a CT scan, and you can see what that CT scan looked like. Just disgusting. Now, that was static air bronchograms, those little kind of white dots that you saw in there, dots and lines. Let's talk about those were static air bronchograms. Now we're going to talk about dynamic air bronchograms. Now you see there's a bunch of white stuff in here, and you see that some of this white stuff is kind of moving a little more than the lung is. See it kind of wiggling back and forth right there and right there? Here's another example. So this looks a lot like the lung. This looks a lot like the liver, but I promise this is a lung. There's the heart right there. You see all these white lines kind of like moving in and out of the screen, going back and forth? Those are what are called dynamic air bronchograms and are thought to be highly specific for pneumonia. One of my former residents called these pneumonia worms the first time that she saw them. So if you see pneumonia worms, think a bacterial pneumonia because that's where they've most commonly been described. You can also kind of zoom in on this if you want to. Here is a linear transducer, big consolidation here, and there are the little air bronchograms right there. And then here is just a disgusting lung. So we have a big pneumonia in that lung. We have a big pleural effusion and a bunch of that wispy stuff in there. This is a pneumonia with a parapneumonic effusion, probably an empyema. So let's talk about the last finding that I want to talk about, which is fluid bronchograms. Now, fluid bronchograms look like this. So it looks like, tissue. Anytime that you can see tissue, remember, it's always abnormal. Now, if we kind of zoom in on this area right here, this little tube looking thing. This is what is thought to be a fluid bronchogram. Now, this is not described a whole lot in the literature, but where it is described, it's kind of talked about as maybe a continuation of that air bronchogram. So air bronchograms, what they are is basically they're like little pus, fluid mixed with air inside of the airways that are like moving back and forth in the little like bronchi as the patient breathes. They'll just kind of move back and forth. And then eventually it's thought to be where it just gets completely completely fluid filled and then becomes that fluid bronchogram. Now, one thing you can do is you can throw color flow on there to see if there are blood vessels or fluid bronchograms. But I mean, I don't usually do that because my thought is that if a lung is so consolidated that I can see blood vessels, it's probably a pneumonia. So I usually don't throw color flow on there. I don't really need to know the difference between a fluid bronchogram or a blood vessel because if I see what looks like a fluid bronchogram, even if it's a blood vessel, you usually only see that in a really consolidated lung, more likely to be a pneumonia, especially with a good pre-test probability for pneumonia. So these are all the findings that we talked about. One of the trickier things is when people ask me, well, what's the difference between a viral pneumonia and a bacterial pneumonia? And I say that the main thing is that you're not doing an ultrasound as like your primary and only way you're diagnosing something in your patient. The ultrasound is a tool in your toolbox. You're not just going to, close your eyes, only look at the screen, the ultrasound screen, just start scanning them, right? You have a pre-test probability, a pre-test differential diagnosis that you are working with before you do that ultrasound. Now, when you do your ultrasound, there are some things that lead me more towards a bacterial process versus a viral process. Now, I will say that early bacterial pneumonia, or to be honest, even the area surrounding a bacterial pneumonia, is very similar to the findings of a viral pneumonia. So with early bacterial is where I'll see pleural effusions, B-lines, subpleural consolidations, pleural line abnormalities, and static air bronchograms. And pleural effusions are pretty rare in viral pneumonias, but they can be present in some of them. And then if I see dynamic air bronchograms, fluid bronchograms, I'm more likely to think that it is bacterial versus viral. Now, one of the things that helps me a bunch is scanning the entire lung. So in viral pneumonia, it's going to be more multifocal, kind of the way that I talked about at the beginning. So patches of abnormalities throughout the lungs. Whereas in bacterial pneumonia, most of the stuff's going to be located in one area. Now, of course, this is not saying that all bacterial pneumonias are going to be focal and all viral pneumonias are going to be multifocal. It's just more likely how they're going to present. Now, this next chart, I'm not going to kind of go through this too in depth. This is more here for you to kind of screenshot as far as which findings are present in which lung abnormalities. And I'll send this out on Instagram and on Twitter later today after I kind of go through to make sure it's all good. But all of these findings can be present in different pathologies, and you really have to think about what is the most likely thing to be present in your patient before you do the scan, and then do the scan, and whatever findings you find, try and figure out what is the most likely thing. I'm a big fan of Bayesian statistics and Bayesian way of doing medicine, and I think that ultrasound helps with that as well. Remember, you're not doing the ultrasound by itself. You are doing your ultrasound and other stuff to figure out if that patient has whatever it is that you think that they have. Don't use ultrasound in isolation. Use it along with the other stuff that you have at your disposal, including the history, the physical exam, labs, and even other imaging in an EKG. You are using ultrasound to help you be a better physician, right? So if you need the ultrasound to help clinch the diagnosis or help rearrange your differential diagnosis, use it. Don't tell anybody this, but sometimes on some shifts, I don't really use ultrasound. It's true. And I obviously am very invested in ultrasound, but I'm invested in ultrasound because I think it makes me a better doctor, which is my first job, is to be a good doctor, right? So use ultrasound along with everything else. Now, there are two other signs that are talked about in the literature that I have to mention. It's these two things, a shred sign and then hepatization. I don't usually think about these as kind of separate things because to me, they're just describing things that are already described. So a shred sign, what it is the white kind of outline of a border of a consolidation. Let me show you exactly what I'm talking about. Let me just scroll back to, not that one. Let's go to here. So if we look at this right here, a shred sign would be this, just like the irregular white border around a consolidation. That's the shred sign. And as far as hepatization, hepatization is just basically talking about bronchograms, which are already another thing that we've already described. So I don't know why we have to say hepatization when we already say consolidation, right? Because hepatization just means lung tissue now looks like liver on ultrasound, but that's what a consolidation is. So I don't really think about that as a separate thing. But if you see this stuff in the literature, know what it's referring to. Shred sign is the border of a consolidation, and hepatization is a consolidation. Now I'm going to finish with the thing that we're all stressed out about right now, the thing that makes me wear masks all the time and like give me a little breakdown over my nose because of the respirator that I use. And that is COVID-19, the big thing that we're dealing with right now. Now, there have been, as of today, there's been probably 2 or 3, maybe 4 things that have been published in PubMed about lung ultrasound. And there's 2 studies that actually give us specific findings. And what I did, and this is on my website as well, but what I did is I looked at the findings of RSV, which has been fairly well described in the ultrasound literature, and influenza, which has been kind of described in the literature, and compared that with the 2 articles that we have on COVID-19 and ultrasound, and these are the findings. Now let's talk about this COVID-19 finding. So viral pneumonias are all going to have irregular pleural lines, B lines, with consolidations of various sizes. Usually they're these small ones, the ones that are like less than 3 centimeters. The new literature that's come out about COVID-19 does mention that there are localized pleural effusions. You got to be careful with that because when we think pleural effusions, we think like pleural effusions, the ones that we find at the base of the lungs. However, this is not what this is describing. And I'm actually kind of confused as to exactly what the literature, the specific article that mentioned localized pleural effusions. I'm kind of confused as to exactly what it means, but the way that they described it in words, have not seen images, by the way, so I don't know how to corroborate this. But with words, the way that they describe the localized pleural effusions is they had a small consolidation with a localized pleural effusion around it. I don't know what that looks like, but this is how they have described it. And then the other thing that they mentioned is low color flow on Doppler in the air bronchograms of the consolidations. I take that with a grain of salt because really no other ultrasound literature has consistently placed color Doppler on every subpleural consolidation. So every single subpleural consolidation might actually have low color flow. We just haven't looked at it before. So I wouldn't throw color flow Doppler on all of your subpleural consolidations that you see, but something that has been described. Now, as far as how to actually use ultrasounds, probably the best way to do it is to use a tablet-based machine. Now, if you have a Butterfly or a Lumify, Probably the best because it's really easy to clean. And in fact, I keep mentioning the website. I'm sorry. I just have my resources are on my website already. So there's a picture. There's this guy out in Vermont named Peter Weimersheimer, who's kind of one of our ultrasound people. And he actually placed his butterfly with the probe and the iPhone and an iPad mini inside of a sterile sheath, and it all fits. That'd probably be the best way to do it if you can do it that way. What we have at our shop is we have a Mindray TE7, which is basically a tablet-based machine. The reason I say tablet-based machine is because they're much easier to clean. So it's probably not a good idea to take your machine in there that has a physical keyboard, because it's very hard to clean that physical keyboard adequately because you get little things inside, the keyboards or whatever. So use that. If you're seeing a lot of patients and are using your ultrasound a lot in these people, consider having a designated infectious disease machine. So a machine that is the machine for COVID patients or suspected COVID patients. And then keep your scan time short and essential. What that means is if you are, your ultrasound, you're an intern, you're doing your ultrasound month, don't go in there and scan a known COVID patient. Right? If they're known COVID, they've already had an ultrasound, don't go back in there and do it. And that's just to minimize risk to the machine, minimize risk to you, to other patients. Keep it short, keep it essential, and try to do everything at one time. So if this patient is sick, you think they're going to need an art line and a central line, wheel in there with all of your equipment ready to go. So you're just in there once. You do your lung exam, you look at the heart, which actually is kind of important because I'm not going to talk about it too much, but there seems to be a high-ish incidence of viral cardiomyopathy in these patients as well. Basically, do your examination, place your central line, place your art line, go out of the room, and then don't go back in there with the machine unless you really, really need to. So keep it essential. This is not the one that you take the fellow, the resident, the medical student, keep it short, keep it essential. So this is how I would suggest you clean your machine if you are scanning your patients with this. And this is a Mindray TE7, which is the machine that we have kind of designated for this at our shop. First thing is take everything off the cart except for the gray tops and a pack of sterile gel. You don't want to use the bottles because that could be a nidus of infection. Go ahead and wheel your machine in there and scan your patient. Just kind of finish up. Then when you're done, before you doff in the room, clean every part of the machine. So you want to clean the probes, the other probes, the handle, the whole machine, the basket, the base, everything. You even have to clean the back part of the machine. Basically, everything of this machine needs to be cleaned to keep it safe. And then after you've doffed, I'm just going to kind of fast forward here. So after you clean it the first time, you're going to wheel it out of the machine, out of the room. Go ahead and do your doffing outside of the machine, outside of the room, and then clean the machine a second time. Yes, a second time. That's kind of annoying, I know, but this thing's airborne, right? So after you clean it the first time, between wheeling it from next to the patient's bed to the door, theoretically, it could have picked up some COVID, right? So once you wheel it out, clean it a second time. There definitely are alternatives and extra things that you can do. For instance, there are some people that I've talked to that have actually put plastic sheeting on the ultrasound machine. You got to be careful with this as well, because actually ripping off the plastic sheeting can actually cause it to spread. So if you're doing the ripping off of the plastic outside of the room, when you rip off the plastic, that movement of ripping off the plastic can actually shower particles outside of the room. So there's different ways of doing this. Do whatever is the thing that is accepted in your institution, talking with infectious disease and whoever's in charge of the ultrasound at your institution.